background light.
Okay. So yes, I think we just attendees are just streaming in. I'm just going to share the okay, initial welcome slides first. Okay, Dr. Kothari said he'll join in like 5 to 10 minutes. While I think so the rest of us are here. Then we already have 40 attendees. So I think you can probably kick off. Welcome everyone to this month's and then the last day of the month. I think we just got it in time. So this month's academic activity of the Neuro-Otology subsection of the IAN. For those of us who are already subsection members, welcome back. Those who are not, please consider joining us because we do have other activities happening on. We have active clinical discussions and case discussions happening regularly in the groups as well. Uh, Today's is going to be a debate. This is on a topic that I think anybody who works with neurology or otolaryngology is usually has divided opinions on, usually strongly for or strongly against. So we have the theory of cervical dizziness today, and we have an excellent uh, expert panel with us who are going to be debating. So we will be starting with an initial small presentation on the Bárány Society's position paper on cervical dizziness. So I will be presenting that. And following that, we will have the comments from the experts, and the attendees are welcome to share their questions in the chat anytime, and we will take them one by one as we go along. I'm just going to share the introduction of all the panelists. So today we are all of you must know Dr. Sudhu Kothari. He was the founder of the Neuro-Otology subsection of the IAN, and he is a neurologist and head of department at the Pune Hospital Research Center, Pune. And we also have with us Professor Dr. Silvana Mazzivero. She's a master's in degree in otorhinolaryngology. She's a specialist in neurotology and otolaryngology. She's a professor at the Federal University of Pará and the University of the State of Pará, Brazil. And she is a journal reviewer, and she won first place for best work from the scientific committee at the Sierra Congress of Otolaryngology and first Otoneurology Conference of the Northeast. She also won the Best Free Theme Award at the 6th International Congress of Dentistry of the Amazon in 2002. The other panel member that we have today is Dr. Diego Olmedo Gallo. He has a bachelor in surgery from the University of Chile, ENT medical technologist. He's an audiologist and affiliated to the University of Chile Clinical Hospital, Chile. And his affiliations are the Ibero-American Foundation for Neuro-Otology from 2025, the Neuro-Otology Study Group, GENO from 2019, and the first place in free communications on the 73rd SOCHIORL meeting as well. Our last panel member today is going to be Dr. Ramesh Rohiwal. He's an MS ENT at BJ Medical College, Pune. He's a consultant ENT specialist at Unit of Care Hospital, Chhatrapati Sambhaji Nagar. He's conducted more than 25 free year surgery camps, and he is a presented at conducted vertigo update workshops and conferences state, national, international level. He's a guest faculty at multiple conferences on balance, including BalanceCon, Bangalore GTCon, Equilibria, and the Middle East Academy of ORL. He has a fellowship in lateral skull-based surgery as well. He is the president of Neurological and Equipneutic Society of India and the founder president of Association of Otolaryngologists of India, Aurangabad branch, and a past president of Indian Medical Association, Aurangabad branch, and awarded best president awarded both state and national AMA conferences. His areas of interest are the cochlear implant surgery, rhinoplasty, otology, neuro-otology, VH, and related tests for vertigo and balance disorders. So I'm just going to start with my presentation. I hope everybody is in. Yep. So 1 second. I think for some reason my sharing is not working properly. Give me a second. Oh. It's happening. Yeah. Okay. Got it. Okay. Yes. Got it. Got it. So yes, we start. I hope everybody can see my screens now. Is that okay? So this is just a primer for the discussion today. The beginning of which this is the basis of the discussion, that is the Bárány Society position on cervical dizziness. This was published in 2022. The first author was Simangal et al. And we have some of his co-authors today with us. We included 13 international authors. It was a multidisciplinary review, and it followed the international classification of vestibular diseases framework. So, what is the position they say? What is the paper in brief? If you want to tell me one word about what the paper is saying, what it says overall is that evidence linking neck pathology to vertigo or dizziness is lacking. So unfortunately, since the evidence is lacking, the Bárány Society declines to propose diagnostic criteria at present. And for what we only have for now is research criteria. There is no recommended therapy at the end of this paper. And however, what they have suggested is we still need rigorous research evidence, which might lead to a change in this position. So the first thing that they took on is, how do we term it? What was the term that is acceptable? There was a initial thing was cervical vertigo, cervicogenic vertigo. Cervical vertigo basically was rejected because the Bárány Society terms that vertigo is an illusory self-motion, which is not ubiquitous in the syndrome. Many of the papers that were published, many of the patients that were described did not have illusory self-motion, which is the definition of vertigo as per the Bárány Society. Since it was not present in all of these people describe this syndrome, it is now rejected. The term vertigo is now been rejected. Most of them have imbalance or lightheadedness, never true vertigo. Another term which was rejected was the term cervicogenic, because what they say is, because if you say cervicogenic, you're assuming a causation rather than correlation. So because when you say genic, it means it's a known mechanism. However, in the due to the lack of current evidence in humans, it would now claim causation, which cannot be supported by the society. So they rejected the term as well. What is the preferred term now that is used is cervical dizziness. It is an association. It's a correlation maybe, but not a causation. And it is dizziness, not vertigo. Why is it dizziness? Because it is now an umbrella term, which can be encompass imbalance, lightheadedness, and of course, vertigo, which can occur rarely. So, and it also takes away that mechanistic implications which cervicogenic did. And this is now consistent with the Bárány Society definitions, which is used for the ICVD framework as well. So what was the epidemiology that they took? They took all the papers, all the published evidence on cervical dizziness, the term that we should politically use now, says. So they took up that what was all the publications, did a meta-analysis, and what they came up is that coincidence is the null hypothesis. So what they found is 68% of people had neck pain, and the population was all over 1,797 people. Of the number of people that were surveyed, they found that 68% had neck pain, and the dizziness was seen only in around 20%, a maximum of 20%. Some studies said 11%, some studies said 20%. So the maximum range which has been found is only 20%. But they also found that in migraineurs, 76% of people also complained of neck pain. So this became a major confounder as well. And when you look at neck pain, there is a 5% global neck pain prevalence, which is a single point prevalence all over the world. And this is the fourth commonest pain overall. So how does this come together? When you put all this epidemiological data together, we know that neck pain is much more common than dizziness. Not all people with neck pain develop dizziness. So is this a coincidental overlap that becomes a problem? And we also know that head movement can aggravate almost any vestibular condition. And we know that vestibular patients avoid movement. They get to secondary neck stiffness. Just like 1 hour ago, I had a patient with a chronic BPPV who refuses to lie down on right side. I tried coaxing her for 15 minutes, trying to do a Dick's Halpi. She flatly refused to relax her neck muscles so that she can actually go into the extension. And so much so that when I try to turn the head to the right, it goes into spasm. And she has severe neck pain as well. And I think all of us must have experiences at one time or other, especially with chronic BPV in the elderly. And another problem is that there is no accepted consensus diagnosis or the diagnostic test for this condition as of now. So what is when you come to the clinical features, so we have the epidemiological look at it, and now we take the clinical data. So we look at all the clinical features that have been described in the literature. There have been 3 consistent features: neck stiffness with pain aggravated during neck movements triggering transient imbalance, a bit of lightheadedness, and or illusory self-motion. So this illusory self-motion is what we use to describe vertigo, that may or may not be there in many of these patients. And neck directed therapy improves the neck pain, improves the stiffness and the dizziness. However, what was excluded? So when you look at the literature, if the patient had no neck pain or discomfort, it was rejected. It was not even considered into this group of cervical dizziness. If the dizziness ever occurred spontaneously without a head or neck movement, and if the dizziness is exclusively positional, that is the change of the head in relation to gravity. Now, if these had any of the patients that were described as cervical dizziness had these features, they were rejected and not included in the classification of cervical dizziness. And again, there has been a lot of theories that have been proposed over the years. What is the pathophysiology that can explain this condition? It's all started with the Barry-Lino neurovascular compromise, that is the sympathetic plexus compression of the vertebral arteries during head and neck movement. But this has been discredited because they could not demonstrate this in studies in animals. When then this was not seen in animals, then this was discredited because it cannot be translated to show it in humans. And then we had the common somatosensory pathology, the somatosensory pathophysiology, that is the cervical afferents, which we know go to the vestibular nuclei. And if the expected efferents from the cervical afferents and the vestibular nuclei output do not match, that is leading to a mismatch, they can lead to a feeling of dizziness, a perception of dizziness. This has been shown in a few cases, shown as weak human evidence. We also had the triggered migraine, whereas patients who have neck pain lead to trigeminal activation, triggering the migraine cascade, which we all know can lead to vestibular migraine as well as headaches. And this became a major confounder in many of these patients. We also have the trigeminal non-migraine stimulation, where the trigeminal vestibular and the trigeminal cardiac reflexes might get triggered during head movement if head and neck movement if there is pain, since we know the trigeminal pathway can have a lot of distribution everywhere in the brainstem. However, this is a theory which is as yet untested in humans and as yet unproven. Of course, the last pathology which we must remember is a carotid sinus hypersensitivity or a vasovagal syndrome, leading to cardio-inhibitory reflexes in the head causes pain. We know that any sort of severe pain can induce syncope, and if there's significant head pain, they can induce mild dizziness due to a vasovagal response. However, this is theoretically possible, yes, but it has not been studied, and we don't know the degree of dizziness that can occur with this pathophysiology as well. So when you talk about somatosensory, there has been theoretical support from animal studies. We saw that cervical afferents project to secondary vestibular neurons, and when the vestibular afferent input becomes unreliable, neck signals partially substitute, and this mismatch can produce abnormal brainstem vestibular signaling. However, when you have a local anesthesia in the neck injection, in across species, this can cause gait ataxia only in one human when they was injected in the neck, but there was no frank vertigo. And again, Botox in neck muscles for dystonia, which as movement disorder specialists, which I do very frequently. I think many of neurologists who fight frequently, we know that this does not cause vertigo in many patients. So if this theory was right, you need to do Botox. What is going to happen is, yes, we are going to block the somatosensory signaling as well. There will be a mismatch, and we should develop a bit of dizziness at least. Again, against this, the cervical ocular reflex, we know the cervical ocular reflex equivalent 40, they tested it in 40 healthy and 30 cervical spine patients. And enhanced reflex can be seen in a few cerebellar diseases. However, this was not associated with dizziness in these patients. Again, weak evidence was that saline injection at the C2, C3 roots at the muscles has impaired eccentric head positioning post-injection, but again, the prevalence of dizziness was low. It is less than 50%, and the deficit persisted after the pain resolved, which is weakening the pain imbalance link again. And against was the RCT was seen in 2008-2014 by Reed, and they did a sham laser versus snag or Maitland laser. There was a mild early dizziness benefit, but no difference at 12 months. The improvement was not linked to head repositioning or balance, and it is again the persistent imbalance and persistent poor responses weakens the somatosensory hypothesis. The most dominant confounder for these patients was found to be migraine. 76% prevalence of neck pain was seen in migraineurs, and vestibular migraine definition, of course, includes head motion induced vertigo. And we know that neck pain is a recognized premonitory feature even before the headache starts, and trigeminal nociception can trigger the migraine cascade. And supraorbital pain triggered vestibular nystagmus in 8 out of 10 migraineurs, and it was not seen in any of the controls. So what this means is that if you're going to study cervical dizziness, please exclude all migraineurs, not just people who are described vestibular migraine, but any sort of migraine, any sort of subtype, because they can sometimes confound your hypothesis. The third common hypothesis, of course, we're talking about trigeminal non-migraine stimulation. We talk about nociceptive afferents from the ophthalmic divisions, and of course, C1, C2, C3, which converge on the trigeminal cervical nucleus. We can have trigeminal vestibular reflexes. They can have, since there's output to the vestibular nuclei. And of course, this unfortunate part is that the Marano study, as I just described, the responses seen only in migraineurs cannot be seen in other non-migraineurs. And there are no prospective control studies in humans with high cervical lesions who are developing this sort of dizziness. Trigeminal cardiac reflexes, again, we know that cranial trigeminal stimulation can lead to vagus stimulation and asystole. So theory is that this can transiently reduce the cardiac output. We can have presyncope. We can be potentiated by opiates, beta blockers, and calcineurin blockers, which are all commonly used in neck pain and migraine patients as well. And Morinaka, of course, said that the neck pain will significantly more likely also develop postural hypotension, which might be one possibility that cardiac reflex is overactive. So there have been people who have tried treatment to see if it works. There's been a lot of interventional evidence. So what do these trials show? There was a snag versus sham laser in 2008. Reasons reduced for 6 weeks, but no balance improvement at any time when compared to the placebo. So only the dizziness improved, but the balance remained bad. So this says that there was a mild positive effect, but this did not persist. Again, this was repeated in 2014, where Maitland laser was done within sham laser, and but again, after 12 months, there was no difference with placebo, and the pain again was not linked to the balance or the repositioning. Malsam et al., which show that the various neck interventions were tried, pain, repositioning, neck stretching, neck exercises. There was pre-syncope in one healthy subject, which, but what was seen is that headache was triggered, which was typical of migraine. Unfortunately, migraineurs were not excluded in the study. And of course, the gone injection study by Baron, which was done 147 people, where they gave gave occipital nerve block in all of these people with neck pain and dizziness. 50% had improvement, no blinding, there was no placebo, and this was a retrospective. And again, we do not know if these people had overlapping migraine as well. There was a significantly high bias. So if we want good research, we would need double-blinded placebo-controlled trials. We need a multidisciplinary team all agreeing on the theory. And we need rigorous exclusion criteria, especially with BPPV and all migraine subtypes. And of course, we have to rule out postural hypotension as well. Most of the people, we will have to lead prolonged cardiac monitoring to rule out other cardiac causes. And we need a follow-up of at least 1 year to show that the effect was persistent. We should have a pre-specified objective endpoints with whether there's any triggered nystagmus, whether the proprioception tests were done properly. So let me summarize what I spoke about for the last 10 minutes. What we know at present is that neck pain and dizziness can coexist. Is it coincidental? Much more likely than causation. And head movement aggravates virtually all vestibular conditions. We know migraine is the biggest confounder. The barrelio-sympathetic hypothesis, unfortunately, has been discredited. Therapeutic response to neck treatment, unfortunately, is not the only criteria to be used for diagnosis. And the only quality RCT which for a neck intervention showed only early benefit and no advantage at 1 year. We may know that cervical afferents can modulate the vestibular signals, but we need more human studies. And the proprioceptive mismatch is possible, but again undemonstrated. GON does help some patients, and the regional cardiac reflexes may explain some pre-syncopal dizziness. And the neck pain, we still do not know. In many pulmonary migraine can be mistaken for the primary cervical pathology. So we need to know, does it exist as a distinct entity with the severe radiculopathy, severe cervical radiculopathy? People who have more severe cervical radiculopathy have more dizziness. Does body rotation with a fixed head provoke objective vestibular signs? Cardiac mechanism underappreciated, and the full high specificity RCT with complete migraine exclusion actually changed the picture. So these are the questions that I would like to put towards our expert panel today. So start with, I see, can we have Professor Silvana? Would you like to go first?
Yes, thank you. First, thanks for the invitation. It's a pleasure to be here sharing knowledge. We all like to share knowledge, especially with friends. Thanks, Dr. Vishal, Diego. I really enjoy discussing cases with you, all of you. Here in Brazil, we have a very important university that we call USP University, and they have a very good research from a very nice friend also called César Bertoldo and Professor Roseli Saraiva, that they did a very good paper where they described cervical dizziness, but they really described this entity only in 15 patients. Uh, and they were testing and looking for the patients for 5 years. So it's not easy and common to find. It's very hard to clean all the bias. You have to see if the patient has, you cannot put in the study if they have migraine or vestibular disorders. So we need to look for. So I believe in that paper, and I try to look my patients always. If the patient has the cervical trigger, maybe he has migraine, but maybe he has cervical dizziness because he has a mismatch, he has asymmetry of the muscles. And we know there's a lot of people say we need to see the patients after one year if they are okay. But let's think if we treat a muscle, and if we do not correct the way that patients look to the phone or the way the patient looks to the stress or how he sleeps, he will do the muscles tensions again. So I think we have to have open minds to believe that and I believe in that paper. Let's see next.
So, yeah, Dr. Diego, would you want to give your opening comments on what we discussed?
Yeah, yeah, thank you, Dr. Srinivas, and all of the attendant. Thanks for the invitation. Well, always, obviously, my discomfort is that almost all of the thoughts that could explain this in the is in the conditional future tense, right? Because there is no clearly evidence. So us, we are scientists, are obsessed with the certainty and with an chiaroscuro, I don't know if I say right, in the first of knowledge, we need to look. So, in my experience in Chile, in the best university in Chile, University of Chile, and also I work in the hospital. In my 15 years of experience, I took like two or three patients that could be a cervical dizziness, maybe. But this patient, like you explained, Dr. Srivas, in the beginning, with this VPPV chronic, like or VPPV untractable, like in 6 or 7 months with the symptoms. Um, I also do another test, maybe not a Dix hole pipe, because all we know we have to put the head down from the horizontal like 30 degrees. I like to use the sideline test published in 2004, yes, 04, by Helen Cohen. And in that movement, you don't move too much the neck. So maybe there is a less discomfort, and maybe we can look better with this distracting, right? But in this patient that I have manual therapy, when the other therapy and the other treatments don't work in this patient. So also is lacking the etiology. There is lacking the treatment, but in my little bit experience, the manual therapy, it's good to, beside the vestibular rehabilitation, the optokinetic exercise for the stimulating the medial vestibular nucleus. So this could be helped, but manual therapy is good for this patient that you can you can it's better get better in that way. So I think that that's the problem we also have with patients with cervical dizziness. If not the lacking of the etiology, the lacking of the possible treatment, but also trying like manual therapy is good for them too.
Would you, I mean, I think this is something that's new that's you brought up. Can you explain more about the mammotherapy that you're talking on?
More about what? I'm sorry.
The therapy that you mentioned.
The, I'm looking at manual therapy.
Yeah.
We also have a formation of like how do you say massage
Okay.
in the neck muscles.
Okay.
So when you put some trigger points, they seems to relieve the symptoms, the symptomatology, when everything else don't work or work a little bit, like vestibular rehabilitation, specific with the visual stimulus or other stuffs, because they have also um, a little test and result of the exams like posturography, abnormality, and but for example, if we do this cervical neck torsion test with the patient with the fixed the head, yes, and and turning on the trunk. Yes, rotated the trunk, the rotation. After and then a manual therapy, effective manual therapy, the patient doesn't express the symptomatology, not pain and not dizziness. In the report, we also know that we have to be more objective with the measurements, yes, but with the also with only considered the report, my patient with manual therapy, they are better when everything is not that good.
Professor Silvano, you have your hand up. Is there something you want to add on?
Yes, it's very interesting what Diego said, because for this group at USP, they use it to treat the patient with the heat. They used to treat the muscles with the heat or nanocarbon tubes, but you can also send the patient, refer the patients to physiotherapists to relax those muscles. And in those patients, they describe it that they were not doing any movement to check. They did all the vestibular tests to see if it was normal. And what was very interesting is that they observed the muscles was different one side to other. They had equipment to see the pressure of the muscles, and it was different from right and left. And when they treated these muscles pressure contractions, the patients relieved the pain. And in this group study, pain was related to dizziness, and the control group not. So they could prove in those patients, but it was only 15 patients in 5 years. So we need to have the open mind, but I think I agree that it's really, really more frequent. We see migraine. So when we think about neck, cervical, we need to think about, is that patient sleeping well? Does this patient has positions that he see all the devices in the bad positions, or does his patient has another metabolic condition? So when we treat dizzy patients, we need to see a lot of things. We need to think, and we have to have the open mind.
Okay. I think you've given us a lot of
Thanks.
about. Uh, Dr. Ramesh Rohiwal, do you want to weigh in here?
Uh, there are many other points which I have included in my presentation. I'd like to share my presentation.
Sure, sir. Yes, please go ahead.
Is it possible?
Yes, yes, please go ahead, sir. You can just share your screen. While we wait for Dr. Ramesh to share, so
Yeah,
this,
yeah. Please, you
sir,
can meanwhile you can continue with
yes, sir.
some other thing, and
Yes,
I'm
sir.
trying to share the screen.
Yes, sir. So this, sir, we want to give in your points as well, whether for or against.
I'm for. I'm for, and
Sir,
I'm ready for a debate.
yes, sir. So I am Dr. Sudhir Kothari, sir. You want to weigh in now?
Sorry.
Yeah, when
Hi.
waiting. Yes, sir. Yeah.
So I'm on the phone now. So I was trying to see better with the computer over there. So what is Dr. Rohibal for? What is the for and against? I'm sorry.
Whether cervical dizziness exists, is it a reality or is it a myth?
Okay. Um, Cervical dizziness exists, but that are we saying? I mean, there are a lot of patients. We all see lots of patients who have dizziness and neck symptoms. So whether it's neck pain or stiffness in the neck. So we have thousands of patients. So they of course exist. But if you
Exactly.
say that it is the cervical spine causing dizziness, they
Yeah.
don't exist.
So there,
So
I've covered in detail about all these minor points which you are talking.
no, it's not a minor point.
Yeah, no,
Well,
no, it's major
no,
point.
no, no, no. My point is the cervical spine responsible for the dizziness, or is it dizziness and cervical spine, cervical symptoms together? What that is the thing. Let's wait for your presentation. Maybe we
Yeah,
can
yeah.
debate after
Just
that.
it's there. It's there now.
Yeah. Oh yeah. Yes, sir. Please put it in
Full screen, yeah.
slideshow. Yeah, yep. The presentation mode, I think we should be fine.
Is it okay?
Yes, sir. Yes, sir. Please go ahead.
Yeah, it is, a position paper. You can say I'm for the cause. Why a separate diagnostic entity remains warranted once the other imposters responsible things are stripped off. Uh, does the cervicogenic dizziness exist? The Bárány Society has changed the label, and there are, the label is so loosely used because many clinicians, and they many times they mean almost nothing, or sometimes worse, they almost they mean anything. There are two parallel risks. Either there is a overdiagnosis, the real disease, which is underlying cause, like BPPV, migraine you talked about, and vertebral artery syndrome, something which needs to be taken care. These patients they get harmed, and sometimes it remains underdiagnosed. The patient with a genuine cervical contribution to the dizziness are dismissed as a functional thing. They are leaving them undiagnosed and they are untreated. My first part is, let's clear the imposters. Three conditions which are real, distinct, and diagnosable. None of them is, in this case, I am making, they are mislabeling any of them as a cervicogenic cause harm. There is a rotational artery syndrome. Second is a BPP with secondary neck guarding, and migraine with a vestibular migraine. Uh, Rotational artery syndrome, everybody knows there is a mechanical compression and kinking of the vertebral artery leading to the head after the whole head rotation and causing the transient ischemia. It can be diagnosed by not only by neck movement, but it needs the other studies like MR angiography and Doppler studies. The dizziness has a vascular origin here, and it is not somatosensory, and the neck is the trigger, but the lesion is in the artery. So the resulting hypoperfusion of the posterior circulation, missing it and labeling it the patient as a cervicogenic can cause a disaster in some conditions. BPPV, many patients we see BPPV, they have got this autolytic debris, they get dislodged, and then patient has vertigo. There is a protective stiffening. The patient learns to hold the neck in a rigid position to avoid the provocating sort of a position, and the neck pain emerges. Sustained guarding produces the real cervical pain, but the dizziness still comes from the canal and it is not from the neck. The harm of mislabeling this as a cervicogenic has to be considered. You talked about this migraine and vestibular migraine. We do get a lot of vestibular migraine patients, those who are considered to be having a common cause, that is a spontaneous vertigo in adults. And the neck pain, it travels with the migraine. Up to two-thirds of the migraineurs, they report cervical pain as a part of their attack, and it is driven by, we all know, trigeminal cervicogenic cervical convergence in the upper cervical cord, but it's not again the primary neck disease. The vestibular migraine compounds confusion because the vestibular component is associated with migraine. What is the cost of mislabeling? This is not only semantic, the migraine goes unrecognized, the BP goes uncured, and the stroke risk they are remain unspotted. The new onset of neck pain and occipital headache with dizziness, think of vertebral artery dissection. Why it matters? Because it can present exactly as a neck pain plus dizziness, which is precisely the phrase that historically funnels the patient into the cervicogenic bucket. And there is a hyperalert clinical posture, first ever severe progressive symptom, imaging of the vessels before putting the diagnosis as a cervicogenic dizziness. And now the second part I'll try to cover. I'll plead my actual case. With the imposters cleared, the residual population remains, and their dizziness is the best explained by interaction of cervical proprioception and the neck musculature with the vestibular system. The argument is built on neuroanatomy and physiology. It's not just a hunch. The neck is one of the body's richest proprioceptive organ. The head stabilization in space, it depends on the neck knowing its own joint position with extreme precision and feeding that information continuously to the vestibular system. The joint position sense, the spatial reference, and online correction, all these things they happen. Vestibular the receptors, the neck proprioception, and the vision together they correlate to one balance. The importance of head stabilization is so precise that the nature has built reflexes around it. You see about the birds, a chicken lifted, swung, tilted by its body, still holds its head perfectly in the space, and the neck does the work, and the feet so iconic that it has been used as a centerpiece of an automobile commercial demonstrating the active suspension. Even this video is used by Professor Harman Kingma in his presentation to demonstrate about the neck and head stability. If the neck were a passive structure, this would not be possible. You again see the air writing reflex. The instant otoliths, they uh, register zero deflection in all directions. Free fall, the head and the torso, they rotate in a so pre-programmed uh, fashion that safe landing is possible. This requires a memory of the exact joint position information and step-by-step motor programs to register the target orientation. Now, the evidence for the correlation. The neck and the vestibular system are wired together and it is demonstrable. CWAMP, which we are using very routinely, it has got a clinical reproducible measurement, neuroanatomical linkage between the inner ear, that is saccule, and the sternocleidomastoid. The neck literally responds to the vestibular stimulus. Fastigious nucleus, anatomically, it has been proved that there are vestibular proprioception, cervical proprioception afferents and vestibular afferents, they are converging in this particular nucleus. And then we have got this vestibulospinal tracts, both medial and lateral. There are two descending pathways. They are anatomically very much demonstrated, and the vestibular system commands the neck, and the neck reports back. If the linkage exists, then the disease also must exist together. Anatomically and physiologically, they are demonstrable, both proprioception, vestibulocervical, and vestibulospinal. Nothing renders them immune to the disease. Like all other neurological pathways, they can be inflamed, injured, or deconditioned or miscalibrated. Therefore, a disease state of these linkages must exist. The disease state and its symptomatic expression is what cervical dizziness should mean. What is a cervicogenic dizziness should and should not mean? Because there is a lot of disparity about the definition. Bárány Society from time to time is trying to clear this, but the confusion continues. A sense of imbalance, lightheadedness, or dizziness arising from a wrong interpretation of cervical proprioception or pain pathways or from imbalance or inadequacy of the neck muscle. Once treatable mimics, they have been ruled out. What it is? It is a diagnosis must be of inclusion based on a disorder, cervical sensor or motors interacting with the otherwise intact vestibular system. What it is not? It is not a waste basket where vertigo and neck pain not sort of diagnosed and they are thrown like anything. BPPV, migraine, vestibular compression, neck dissection, etc. They are different diseases and they needs to be ruled out. Now, clinical investigation footholds. We are not starting from zero. We have got clinical observations. Patients undergoing torticollis surgery, they have got dizziness for several days post-operatively. When the neck proprioception map is suddenly rewritten, the vestibular system has nothing wrong with it, yet the patient is dizzy. This is the cleanest and the natural experiment we have for a cervical contribution to the balance. About the test which Dr. Srinivas talked, this is SPNTT, that is a smooth pursuit neck torsion test, and the efforts are going on. It is already proposed to be a candidate test for cervicogenic dizziness, and the foundation is laid for refinement, validation, and standardization of this particular investigation tool. So, where we go from here now? Recognize the entity, build the criteria, and treat the patient. We have to diagnose the imposters first. BPPV, migraine, vascular causes, dissection, all they mimic, they are to be ruled out. Define the residual entity, build clinical and investigational criteria, refine SP and TT test, and adjacent test, agree on what we are looking at, and treat what we see now. Develop neck targeted strategies, proprioceptive retraining, motor control, pain modulation, and the other study outcome. The question is no longer whether this particular entity exists or not. Neuroanatomically, honestly, we must recognize it and we should treat this particular entity. Thank you very much.
So I think you made an excellent case for the presence of cervical dizziness, giving a lot of anecdotal as well as possible theoretical basis as well.
I've tried to cover whatever
Yes,
was possible.
yes, sir. You've given a very, very
Was a
comprehensive.
very long back in Jaipur conference, I had presented a similar sort of a paper in NESCON, and a lot of things are now modified. It was 5 years back.
Okay. I think Dr. Avinash had asked, what is the hypothesis for the manual therapy? And is it just relaxation? Can it also just be a migraine causing the dizziness just responding to manual therapy? Diego, you want to respond to that?
Yes, about the manual therapy, how to
Yes.
do it.
No,
Okay.
so actually, no, the theory was the question was whether manual therapy, because it's improving vertigo, at least the dizziness, is it just that it's relaxation which is actually helping a migraine to respond? So how do we take this as how can we use it as evidence when we know that it also helps in migraineurs?
Well, it's difficult because there is a lack of evidence too. For the manual therapy in these cases. There is no exquisite study with everything good in the methodologies, right? But I think this, if we do the manual therapy in both cases, well, with certain um, with precautions of obviously the dissection of artery on the vascular syndromes associated with this. Yeah. That's why we always have to do this test before do anything like this. I mean the imaging test or anything about that. So you can not look for the central dizziness or central etiology of this and making a worse of the patient. So if you have all of the tests of the neck, the imaging test, and you don't dismiss right the vascular compression syndromes around it, I think the manual therapy is good because is one is cheap, two there is no working about this. There is no a better or wellness of the symptoms. You don't leave the patient worse than we arrived. So maybe you can have this test before, and then you can try to do it, or you have to derivate to a specialist of manual therapy, and then how to do with the patient.
Okay. So I think the first step would probably be proper diagnosis before we attempt
Yes.
the manual therapy, isn't it? So I think that's where it's kind of the question lies. Uh, I think the Dr. Karthik Harishankar has asked, we do see patients who have cervical disc disease, compressive disc disease on MRIs, and they have vertigo. So how do we know this is not an actual association? I think that's what we have been trying to take, isn't it? So this, sir, you want to take this question?
Yeah, I will try to answer this question.
Yes, sir. Yes, sir.
What we see many times, the cervical spondylitis is labeled as a very common cause for vertigo, and you will see many people wearing those particular belts very regularly with a firm belief in their mind that it is going to give them relief, which doesn't give relief. We have to rule out the underlying other causes, and then only we can treat them.
So this, sir, you want to talk about?
Yeah, so I have yet to see a patient of cervical dizziness, cervicogenic dizziness. I see lots of patients, like Dr. Rohiwal said, who come with collar, who come thinking that their dizziness, their vertigo is because of the neck, but they are either BPPV or they are migraine. Some of them are triple PD, and very rarely do you get vascular. Those are things acute ones where you get rotational artery syndrome, etc. That is an interesting, curious entity. All neurologists like to think of rare things first. That is very rare, and you have to really prove it. You have to hold the patient's head and move the body down, and then show that that is causing dizziness. Then that is really the artery is getting compressed. Uh, we all know that if a artery is getting compressed, you are not going to just get dizziness. You will get diplopia, you will get dysarthria, you will get brainstem symptoms. So just getting vertigo, positional, or whatever, majority of these are BPPV, and it is the most common cause actually of neck pain and dizziness will be migraine. Now, uh, there's no question that Dr. Rohiwal did a very nice presentation that how neck should cause dizziness, but does it cause? We don't know. Nobody has ever shown that. So the Bárány Society has come out. We have come out with the statement in 2022 that there is no evidence of any relation between the neck and the semicircular canals. There is, yes, you do have a relation with balance. So therefore, every dizzy patient is scared of moving the head. When you move the neck, your head moves, and the balance system is a sensor for detecting movement. So every patient with vertigo is going to get worse on moving the head. So they feel it is very difficult to move your head without moving the neck. Therefore, people attribute it all to neck, but it is all head movement and the balance system which is moved that causes. Very important point which Dr. Rohiwal did bring out is migraine. Neck pain is very common in migraine. We often don't think. In fact, I have a migraine just now and I'm getting neck pain. So migraine can present with neck pain rather than headache. Now, remember that. You don't have to have only headache. Um, See, the problem in saying that could it be cervicogenic, could it be this, is you will miss. People don't then look for the treatable things. Yeah, Dr. Rohiwal can easily rule out BPPV and the other condition. But those who are not such experts will miss BPPV. It's very easy to label something as cervicogenic dizziness and then send for physio. The guy will improve after 6 weeks anyway because BPPV does improve. If you don't do anything, also no maneuver, no things, BPPV will improve. Migraine will improve sometime or the other, but you miss the chance of treating it. You are not explaining the patient what it is, and therefore I think it's very important to diagnose. Let's not first go into treatment. Uh, is manual therapy cheap? I don't know. In India, it's not. Treatment of migraine is cheaper than sending to a physiotherapist for migraine therapy, for manual therapy. Because once you go there, then they'll start needling, they'll do all sorts of things, and this thing will go on and on. Number of sessions will go on. So I don't agree that it is cheap. Just because it doesn't harm the patient doesn't mean we should do it. Okay.
Fully agree with you.
So you 10 times you must rule out BPPV because that is so treatable. When a patient says that he moves the neck and he lies down and he turns, he looks up, looks down, please rule out BPPV. And migraine is really a chameleon. I mean, how can you rule out migraine in a patient who comes with constant dizziness and things? It's very difficult to rule out triple PD and migraine. So, and they will feel better with manual therapy. They will feel better with massage. So, are you saying the migraine has improved with massage, or it is the cervical spine which has improved?
I think the problem we face that we don't have a gold standard test for migraine as well, sir. It still remains
Yes, there
very
is no marker. There is
there's
no
no marker.
biomarker for migraine.
I think that makes that it's something that's a big confounder, unfortunately. Uh, yeah,
Yes,
in this
Dr. Srinivas, see, migraine is a disease which has been diagnosed by a number of specialists coming together who decide that this, and this, but not that is migraine. But this is just few specialists. After 5 years, some other guys will come together and say, no, if you have this, that is also migraine because there is
Even
no
there is a
biomarker.
very common overlap between menials and migraine. There is a lot of overlap.
Yes,
agrees.
absolutely. So there are no marker. There is no marker. You have to diagnose. You have to see, is the symptom triggered by stress? Is it relieved by relaxation? Does the patient have a long-standing history of thing? If the patient has stress, late nights, traveling, not eating time, and then gets neck pain and dizziness, I would err on the side of migraine.
A very good point is brought by Dr. Avinash Bijlani, who is in the chat box, has commented that patient getting relief with the treatment for migraine is a marker for migraine.
No, I don't agree. The problem is migraine is a disease which has been treated for years. Migraine has a very high response to placebo. So the if a patient goes of migraine goes to Dr. Avinash, even if Dr. Avinash gives him some homeopathic pills, but it is Dr. Avinash who's giving it, the patient will improve. So improvement because of therapy does not make a diagnosis. You have to go by the whole thing. What is the pattern? What is triggering it? What relieves it? What findings do you see? Do you find any nystagmus or not? Then you call it migraine. But treating it and relieving it, that relieves it. I won't agree. It's fraught with risk.
That's a good question just come in the chat box. Dr. Marami Das has asked, so sometimes we have patients who have neck pain, have a severe neck pain, radicular pain, and then a few days later they develop extreme giddiness. I think I like the word time that she used the word giddiness rather than vertigo. And she's asking, is it related or how do we say it is not related? I think in
Um,
the terming of giddiness,
Yeah,
I think very important.
so
Yeah.
if it is pure spinning type of vertigo, when the person lies down and you get brief attacks of spinning, that is not due to cervical spine. But when you have an acute spine spasm, the spasms of the muscle, at that time you may feel a little unsteady, you may feel slight so-called dizziness, non-specific. It will not be vertigo. That is known in an acute cervical disc when you have a spasm of the cervical muscles. Again, from my own personal experience, I'm telling you can feel slightly dizzy.
Okay. Dr. Diego, you want to add on? You have your hand up.
Yes, I want to say something, but I think Professor Dr. Silvana is first. Do you
Okay.
first?
Silvana, yes, please go ahead.
Um, I was listening and I really enjoyed all the lectures and explanation, but I would like to think about in a parallel. Diego, try to help me with the English paralelo, because when we have tinnitus, we have the trigeminal trigger points, the muscles, the contractions, and here we use manual therapy, we use acupuncture, we use dry needles to release that contractions, and it helps. And most of those patients, they have the mismatch. So it's easier for us to make the parallel and think about dizziness, not vertigo, but dizziness when we have this in the cervical. So I really believe in the mismatch theory, and I prefer not to rotate the trunk or move the head. I prefer to feel the muscle pressures, to touch the patients, or to here in the neck and feel the pressure if I can see the asymmetry. And usually I have a good physiotherapist that could work with me and try to release these contractions, and usually we see the patients, they improve. But those patients usually are stressed, they do not sleep well, they don't go to exercise, they look to the phone like this all the time. So this will continue and repeat. That's my experience. Diego.
Silvana, these are the patients we would diagnose as migraine who are improving with the relaxation therapy that you and your physiotherapist are
Yes.
doing.
Yes, I agree. We have a lot of overlap patients with migraine. I agree. And we also has a lot of BPPV patients that it's not BPPV. We treat migraine and they improve. So I think our dizzy patients, it's really complex. So we need to think in all those criteria and look for the patient very, very carefully. Thank you.
Thank you, Professor Silvan. I think, sir, I just want to add in something. I think even though they might be treating migraines, I think it is safer than giving beta histine for all my people who have vertigo. This might be a better way of treating than giving beta histine across the board for any and all vertigos. Yes.
Magic drug.
Yeah, magic drug, exactly. So I think this might be a better option. At least it takes off of migraines, which I think which are much more common than we tend to realize in many patients. Yes.
Yes,
Dr. Diego,
yes.
yes.
Well, I want to tell a few aspects we can help us for this, but the for the differential diagnosis. For example, I know everyone know vestibular migraine is very difficult because they don't have a biomarker, etc. But if we look and we have the look um, as to see this in an ictal period, patient with an ictal period, you see an spontaneous nystagmus 70%, you see an positional nystagmus for maybe the second theory of vestibular migraine, the vascular trigeminal theory, for maybe there is a change in the density of the endolymph with the cupula. So that's why you see a nystagmus, a positional nystagmus, but it's no BPPV. Or maybe you have a TBI patient with VPPV, but also with agnosia vestibular. So you have to see the nystagmus, but they don't feel the symptoms. So there is a lot of things we have to look for to know, and there is difficult to do as well. So if we are looking for the best tools to understanding vestibular migraine or BPPV, we also for like a consequence, we have to look for the neck cervicogenic maybe dizziness if if you discard everything else that I mentioned. So, for example, another stuff in BPPV is unfrequently, but also we see is canally jam. You see a positional nystagmus, right? But doesn't release with the typical maneuvers. You have to do something else. And maybe you think it's not a BPPV, but is it a BPPV? It's a canary jump. So you have to know and have the tools to understanding and do a better diagnosis. And then we have this dizziness cervical entity. So it's difficult.
If you look for metabolic disorders, some metabolic disorders are related to migraine. So that's why I was trying to explain the how complex is to treat dizzy patients. We cannot only look for one aspect. Even for BPPV, when a classical BPPV that it comes like easy patients, maybe the conditions that we need to look for to avoid repetition. It's not easy to be a dizzy doctor. It's a challenging. We love that, but it's a challenging.
It's absolutely a challenge. I mean, I just want to tell a story of what patient I saw yesterday. There was a young boy who came with 1 year history of repeated episodes of dizziness. He feels dizzy when he's working. He has his own garage. When he lifts up some weight and doing some work, he feels dizzy. Then he goes and sits down for 5 minutes, feels all right. Sometimes he gets it without reason. And I would have thought this guy is psychogenic, he's functional. But the referring ENT doctor, I won't say who, he was very good. He had done a scan of the ear and he had shown that he had superior canal dehiscence. He just sent it to me that you confirm it before I operate. And yes, he did have superior semicircular. So you can have all sorts of patients. From history, it looks functional. But unless you look for that specific thing, it would have been missed. We normally don't do a CT scan specifically at those sections, thin sections, to look for superior semicircular canal dehiscence.
Sudhir, nowadays, there is more and more awareness about the superior semicircular canal dehiscence
Yes,
because a lot of
yes,
cases are coming up, and we are having now a lot of good sort of imaging tools. Earlier,
yes.
these cases were missed, I think, probably.
I think so. I think so. In fact, I thank that ENT doctor that this is just the second patient of superior semicircular canal dehiscence I'm seeing in life. So I must have missed so many.
I think we have somebody who shared a very interesting case where they said that Dr. Devi Prasanna has said, I myself developed classical posterior semicircular canal BPPV after I took bed rest for the cervical disc prolapse. And the immobilization of the neck triggered the BPPV. Is that a possible hypothesis as well? For somebody developing BPPV vertigo after a neck pain?
No, see, what happens is if you are remaining in bed in one position, everybody, the otoliths get loose, but they get dispersed and dissolved. But if you remain in one position, so fracture neck femur, the person is lying in bed with traction or something for a few days, or sometimes I've seen after eye surgery or anything. If the person remains in bed for some time, then those particles come together, they clump, and then they cause BPPV. So it is not the neck causing BPPV. How can neck disease cause particles in the ear to get dislodged unless you had an injury which affected both this and ear? It is prolonged recumbency. Prolonged recumbency itself can cause BPPV.
A long period bed rest, it is very common sort of a entity we see for
Absolutely. Yes.
having
Yes.
reporting as a BPPV. Very common.
Can we get Dr. Avinash also into the panel? He will have a lot of things to add.
Yes,
Dr.
sir.
Avinash,
He's part of the panel. He can unmute himself, sir.
Hello.
Yeah.
Hello. Hi, everybody.
Yeah,
Yes.
you are audible, Avinash.
Yeah. So, I mean, somehow I have not diagnosed a case of cervicogenic vertigo till now. That's what I have to say. I have always found some or the other cause in these patients. Of course, uh, practically, I personally feel that why it has come into so much of this myth is so popular and rather believed so strongly is because whenever they get a neck pain, they go to an orthopedician, the patients. And whenever they get dizziness, they are also themselves linking it to it. And no offense towards the orthopedicians, they just add one of these labyrinthine sedatives and make the patients rather strongly, further strongly believe in this myth. And Dr. Rohiwal sir did talk about the rotational vertebral artery syndrome and all those things. In fact, I was also seeing a patient at that time. So, in fact, unfortunately, I missed a part of his talk. So, that's a rarity basically. It's a rarity. And moreover, true vertigo can never be cervicogenic because that arises from the pathways of the semicircular canals, and the neck has got literally nothing to do with it. And another thing which was very strongly pointed out towards the beginning of this discussion by Dr. Srinivasan also, and he said that the cervicovestibular or cervicoocular reflex is rather vestigial in humans. So I think whenever we see a patient who has been labeled with cervicogenic vertigo, we should definitely take it with a pinch of, or rather not with a pinch of salt, but a spoonful of salt.
No, sack of salt.
Oh, great, sir. So you further emphasize what I'm trying to say.
Yes. Yeah. No,
So I think
I
we are
have
in agreement.
seen a single patient till now who I will say is due to this. I think
Exactly, sir.
all of them are either BPPV or migraine. They
I would,
might see the problem in this cervicogenic hypothesis. The only
yes, sir.
problem is that you are further increasing this myth of relation of vertigo and neck. So patients of BPPV will get missed.
True, sir.
Migraine will get missed.
After so
So
much of deliberation,
yes,
the Bárány Society has come to this conclusion, in fact.
that it is not there.
So,
Not
yeah,
there.
exactly,
That
exactly.
that's the thing I had emphasized in my talk, that these other conditions, they need to be ruled out first.
But Ramesh,
True,
that's
sir.
what I'm saying. When we say they need to be ruled out and then we talk about this and give it importance, see, it's very easy
Small
for
small percentage of cases still remain unexplained.
but see, I mean, like if it's unexplained, that is not what our statement was. I was part of the statement that the Bárány Society we came out with, and we have come out with. We at present we do not feel that there is any evidence of. I wanted actually Dr. What's his name? Sorry, I forget the one who was the lead author. UK wala, Dr. Pawar will remember his name because we emailed
Dr.
him.
Uh,
Professor
Bronstein,
Barry.
Dr. Bronstein.
No,
Barry
Barry,
no.
Barry,
Simangal. Barry Simangal.
Barry,
Simangal,
Barry.
Barry
Barry.
Simangal.
So Barry was the one who initiated this, and Dr. Simangal, who's in London, and I had actually requested him to give us a 10-minute thing on what his take on this is, and he, of course, does not believe that it exists, and it is. I was lucky to be part of that team where we came out with a statement that no, at present there is no evidence. We need more studies. So as of 2022, at least the last time a systematic study was done, there is no evidence that you can link these two. Yes, neck pain and dizziness are very common together.
That's what I had put in my talk. Neck pain and dizziness,
But
not true vertigo.
neck disease does not cause dizziness.
No,
Neck
no.
pain and dizziness go very commonly. For
They
So
are
two
not
I think
reasons.
I think
common. The
I think they're
causative element is
splitting
different.
hairs. I think we are splitting hairs because I think the Bárány Society was very clear that we should not take in vertigo. We take vertigo out of the equation. Do not use the
Yes,
term
yes,
vertigo at all. I think that
yes.
was
Yeah,
very
yeah.
clear.
Not only that, they
Please
also
do not
say
use
that
vertigo.
don't call it cervicogenic. When you
Yeah.
say cervicogenic, you are trying to imply that it is the cervical spine which is the cause.
But
It's
Professor
just
Silvan,
cervical vertigo.
the Professor Silvan, I think you just mentioned that you can see torsional nystagmus rarely in these patients on the VNG or COG. So how frequently do you see these changes, or what triggers these changes? Is it
Is it positional
Personally,
cervical torsional nystagmus, Dr. Silvana? Is it positional?
yes, that
Then
that
why
case
is it
was not
then why
that
is it
case.
not for BPPV? Why is it
Yeah,
not
that case
BPPV?
was not my case. It was that group at USP, that the research group, Dr. Roseli, Dr. Bertoldo. They had a patient that had it was like a patient like BPPV, but they did not did maneuvers to reposition. They did the muscles treatment with the heat and the maneuvers and the hand manual therapy, and the nystagmus disappeared. But personally, in my office, I never saw. And of course, if I have a patient like that, I would try to do the reposition and maneuvers. But I would like to remember that when we say cervical or neck or diseases like that, we could not forget the vascular asymmetries in the basilar, in the arteries that could be normal, but even when we age, maybe this could be a problem. The vessels could have could be more. Diego, help me. Duro, it's
Project?
thick, more thick,
Is thick.
Yes.
and
Yes.
then we can
Yes.
have some other circulations problem. And if we turn the head, or if the muscles could be more contracted. So here I try to look everything. It's not easy. And I don't like when I see the asymmetry with the arteries. And when I receive the image, oh, this is normal. The patient has this since birth. Okay, I agree. But when we age, the vessels, it's not very soft as we did when we were a child. That's only the way I think when I see my patients, that I would like to share with you.
Well, I think you brought in an important part of the discussion. I think should we take up where does the component of vestibular basilar insufficiency, is that an accepted something that can be accepted as a possibility of cervical or cervicogenic or cervical dizziness as well? So that is something I think many neurosurgeon friends are very happy to write as
Yeah.
possible diagnosis.
Because even BPPV, they will call it vestibular VBI. No, no, no. Yeah, I mean, luckily, though we age and our arteries become stiff, we don't get vertebrobasilar insufficiency. Dr. Silvana, we are lucky. Our arteries are quite good. Even though on moving the neck, you don't get, even somebody with severe basilar disease does not get vertigo or neck movement. They get stroke, they get TIA spontaneous, but not because of
Yeah.
neck movement.
Yes, we have another research in that university, because I always talk about them because this is the main university that we have in Brazil, and I use it to visit them a lot. I really love this group. They have a research on vascular dizziness or vascular disease, and they are measuring the amount of the size of the vessels and trying to relate to other complaints, not only strokes. And I will try to get those papers and I will send to Vishal so they can share with you, because I think it's very interesting. Because, I am ENT doctor, I am not a neurologist. So I need to learn with people that knows that. But we have a very good group studying that, and we see that some patients that we say that they have the normal vascular pattern, maybe a little asymmetry, but we can correlate to some autoneurology symptoms. So I will send the papers. So I am learning also. They are learning also. And as I said, I like to see my patients as a global symptoms, and it's an entire patient, not only one symptoms. Who knows?
Well, I think we are seeing questions like, can dolichoectasia cause dizziness? I think only dizziness, you should be very careful. If the person has other brainstem symptoms, yes, I would consider vertebrobasilar. but it is very easy to label any dizziness and blame it on the the blood circulation, and then start the patient on antiplatelet or similar, which is dangerous. Giving somebody who does not have cerebrovascular disease, giving him antiplatelet therapy is putting him at risk of bleeding. We should not be giving antiplatelet therapy just because of a vague feeling that maybe he's old, maybe this could be ischemia. These are not innocuous therapies.
Hmm.
And so I think Dr. Sheetal Nayak has actually mentioned in the chat. So regarding the semantics again, the neck doesn't generate dizziness or vertigo, but when you talk about the proprioception afferent-efferent mismatch, why should we not call it cervicogenic? It is of course the contributor, isn't it?
I had this point in my talk.
Yes.
If you want, read the paper that we have come out with in the Bárány. It's an open. It's available on free. Why it should not be called cervicogenic? Because we have no evidence that the cervical spine is responsible. The two go together, but cervical spine is not the cause of the dizziness, and therefore it is not called cervicogenic. That is the Bárány statement.
Okay. Dr. Minal Kantire has put his hand up, sir. Is there anything you want to add in?
Hello. Am I
Yes,
audible?
yes, sir. Welcome, Dr. Srinivas. Yes.
Am I audible, sir?
Yes, sir. Yes, sir.
Yes, Dr. Roy.
Yeah,
Yes,
yeah.
yes,
So
you are
it was,
audible.
it was an excellent discussion, and I have learned a lot, especially when Dr. Kutare is here. We everybody learned from something from him, and Srinivas is coming up and a big neurologist in the country. I have also heard about the other speakers who have done very well and justice to the subject. I feel that last 35 years or so, 37 years of my practice as a neurologist, I don't make the terminology as cervicogenic. That is actually a misnomer, totally a misnomer. Because if you see about the anatomy of the vertebral artery, they go, if anybody has got a neck pain, they go to an orthopedic surgeon first. And that orthopedic surgeon will ask for his extra cervical spine, epi, and lateral view. And invariably, the report will come as cervical spondylosis. And everybody will give blame to the cervical spondylosis for this vertigo. So that is a very common belief. Even all the physicians believe like that. Some of the neurologists also believed previously. But actually, you see, if you see the vertebral artery, they passes through the foramen transversarium. So if there is a disc prolapse, it has nothing to do with the foramen transversarium.
No
It
relation.
is
There's
in a
no relation.
different area.
Yeah.
So it is not the vascular compromise at all. So there could yes, rarely you can have a vertebrovascular insufficiency, but that syndrome is an entirely different entity. Because in
And
those
very rare.
situations, yeah, you should have a diplopia, you should have a dysarthria, you should have a dysphagia, all the brainstem symptoms, or maybe some sort of a TIS you can get. But you don't get the neck pain arising out of the cervical region, you get the neck pain. You don't get the vertigo. It should have affected the vestibular system. But how the neck can involve the balancing system of our body? So these concepts should be very clear to everyone. I have also learned from many things from you, and thank you very much for such a discussion. That was my comment on it.
Yes, thank you, Dr. Roy. So, this vertebrae, we had a very nice patient. I think Dr. Watts also had, where we have shown when you turn the neck to one side, you may get diplopia, dysarthria, but even if you don't have, the patient gets downbeat nystagmus, vertical, torsional, and that is immediately relieved on when the patient moved. So there was clearly, definitely vertebral arteries, and the patient would start shouting. This was not BPPV because it was not on lying down. The head was straight, but you moved his body and he would get. So it is. These are very rare patients where there is vertebrobasilar compression.
I think
The problem is somebody still saying that cervical spine contributes. Yes, in acute situation, when somebody has acute neck spasm due to a disc, then transiently you will feel slightly dizzy. As I told you, I have had that. When you get a neck spasm, you may get transient. But these are not the patients we are talking of. We are talking of patients who go with all the time feeling dizzy. They get an X-ray cervical spine, it shows a bad cervical spine, and we blame the spine on it. So chronic cervical spondylosis does not cause
Never,
dizziness.
never. I think Dr. Srinivas or Dr. Ajay was they needs to be unmuted by Dr. Srinivas.
I think
I
one
was
second.
wondering where is Vats? He's there.
Yes, he's
Right
joining.
there.
I'm here only, sir. Only have to add, you have very rightly said that the cervicogenic it means something arising from the cervical spine. In past 6 months, I have two cases of the Bow-Hunter syndrome. The first was a case of vertebral artery dissection that was thrombosed, and the patient was seeing the television in an abnormal position with hyperextended neck and the hands capped on her cheeks for long periods of time. And that she recovered with that, and she had a Bow-Hunter syndrome on account of that. Another patient, which is still in submission process, is a patient with a cervical rib arising from C7 vertebra, and where we had demonstrated that there, on turning the head to the right, there was a ischemic nystagmus that was probably downbeating or upbeating, and she had a skew and as well as a ischemic right sixth cranial nerve palsy during that time. And as soon as we resumed the neck in the straight ahead position, it disappeared. And on the CT angiography, we could show the dynamic compression. So anything dizziness which is related to the neck structure and leading impingement of the either the cervical vertebral artery, extracranial vertebral artery, or something, if you want to add it more, then it could be a subclavian steel syndrome that could result in the dizziness. So we need to be very clear that all alone, without the involvement of the vertebral artery, extracranial vertebral artery, we cannot label this as cervical dizziness. And the dizziness has also been redefined in 2009 by this Bárány Society. That's all I have to say.
Thank you. Thank you, sir. That's a good summary of that point as well. I think there's one question which was still not taken from the chat. Somebody's asked about patients. Some people have heaviness in the head with the fear of fall due to loss of balance. None of these, no neck stiffness, no tinnitus, no BPPV on exam, not responding to vestibular rehab. How to go about treating these patients? I think before we go ahead, is this? I would assume that this is PPPD, but I
Yes.
will leave it to the others as well.
You're absolutely right, Srinivas. These are most likely patients
Yeah,
of triple
100%.
PD.
100%.
And triple PD is
Yes, sir.
requires
But I'm
clear
again,
diagnosis. It's a functional disorder. You will need to make a positive diagnosis, and they are very treatable. They do improve, and you don't need beta histine for them.
and he said that there's no response to vestibular rehabilitation therapy. Is
See,
that
the
not
thing
only
is,
rehab?
yeah, it's not just alone. In these patients, the first thing that is we've done a thesis, we've not published it, but it's very important that the patient understand what is happening. Just chronic dizzy patient, you say, okay, go for physio, they don't improve. You start antidepressants, they don't improve. You send to a counselor, they don't improve. But if you sit down with the patient and you explain what has happened and he understands why he is getting whatever he is getting, then he will respond to all the treatments that you have. So functional patients, like all other functional patients, they need to be involved in the diagnosis. They need to accept that yes, this is functional and this doctor knows why it is he's calling it functional. If they feel that because you can't find anything you're calling it functional, they'll not improve.
So I think I will 100% agree with you. I recently had a patient who was a clear-cut patient of triple PD. I will not go into the details of the questionnaire that he answered positively to, but just to reiterate what you just said, I spent 45 minutes talking to that patient, explained to him that this is your problem. Then many of these patients, they have this visual vertigo, vestibular visual mismatch. I explained to him in a layman's terminology. I told him this is not a disease. This is just a variation of the normal, things like that. I put him on Triptomar 10 mg to begin with. And I also told him about the rehab exercises. Now, why I'm specifically discussing it out here is because you said the medicine may not be helpful, the rehab therapy may not be helpful. Their understanding of the problem is much more helpful. He came back to me after 1 month instead of the 15 days time I had given him. He, excuse me, sir. He came and said, I'm 80% better, doctor. I stopped the Triptomar 15 days back. After stopping the Triptomar, I am just the same, no deterioration in my condition. And I'll be very honest with you, I did those exercises only 4 times because I was lazy about it. And the result is there. And the same patient has put up a 5-star review for me also. And it just happened when yesterday. So I couldn't resist myself the thing all over again.
The
So very
easiest way, Avinash, I explain it to the patient. Of course, a lot of counseling is needed, and I tell them that there is no serious problem with your hardware, but there is little problem in your software, and they feel understood.
I think we're digressing from
Post,
the topic.
Srinivas needs to be unmuted, I think.
Yes, sir. So I think we're just digressing from our topic for the day.
Yeah.
Uh, we've gone beyond the 90-minute mark. So in the interest, I don't want us to be get cut off. This happened the last time we had a panel discussion where we ran out of time. So I think we're just going to start. I'm going to ask for closing comments from all the panelists, starting with Professor Silvana. Do you like to give us some closing comments?
Srinivas, can I talk next? Because I have to go somewhere after
Yes,
this.
sir. Yes, sir. Yes, sir.
Sorry, I was reading the message in the chat. You mean that I need to talk about this question?
No. So just any closing comments for
Summarize.
the discussion.
Closing comments, just like that. When I think neck, I don't think only in cervical. I see all the patients. We need to look for every structure, and neck is part of proprioceptive, and this is important for balance. So we need to consider in any way we need to consider. Okay, thank you so much for the invitation.
Thank you. Dr. Sudhir, yes, you can go
Yeah.
next.
So
Yes.
I made myself clear that I blame the thing above the neck more, the brain and the inner ear. So it's BPPV, migraine, very rarely vascular. Uh, don't bother much about the neck, and don't do X-ray cervical spine.
Uh,
Uh,
Srinivas sir has joined. Dr.
yes.
Srinivas, can you
Yes.
please unmute and
Yeah,
give
he
your...
is unmuted. He is unmuted, sir.
Yeah.
He can speak.
So, see, we do this course for my. This thing is my point here is we do this course where we train people from both MBBS background and the physiotherapy background. And most of the time, after the course, that I've been told by the physiotherapy friends is, sir, I never realized that a migraine would be causing neck pain. And so many of these patients in whom we used to be simply trying to handle the neck, thinking that it is the head, neck is the source of their all the pain. When migraine has been recognized, so many of these people are getting benefited. So that is one common, in fact, very common feedback that I get from the physiotherapy side course participants. So that is a very important point. Second thing, as Dr. Sudhir Kotari sir so beautifully told, so, so many of these people who actually have proper recognizable proper cases of BPPV are going around in cervical collars for months together, years together, and so once we treat them, it's all great. But somewhere we should also keep an open mind that maybe in the future, maybe some of these, like for example, Dr. Sudhir Kotari sir told about a patient of superior semicircular canal dehiscence. If not for that particular imaging, uh, there was no way that patient could have been diagnosed, and probably that person would have been labeled as functional. Okay. And then there are people with only inferior vestibular nerve not working. So many of these people who have been labeled as triple PD, but then when we find that only inferior vestibular nerve is not functional and then we start giving specific rehabilitation, they really start doing well. Probably a day will come like how we have a measure before HRCT, superior canal dehiscence was not there. Before we started doing V hits and F hits and all these things so regularly, the single canal deficits were difficult to find out. Probably there is going to come a day in the near future, probably in our lifetimes, that there is going to be a similar measure, and when that comes, all this will be settled. As of now, we don't have a measure, but we should have keep a open mind that maybe there will be a measure if at all neck is contributing. Okay, so just an open mind, but as of now, as things stand, more harm is being done by that word than good. But we should keep in mind that someday maybe that word also will become honorable when there is a specific measure. Okay.
Thank you. Thank you.
Thank
And
you, sir.
Diego, do you want to add on your closing comments as well?
Well, my last comments would be maybe look for um, enhancing the test, but it's difficult. Yeah, we think about the vamps, the CVamp, okay, but we need to compare a control group with another group that we know they have cervical dizziness, and for all of we are mentioning, it's very difficult. So if we can do, for example, the cervical neck torsion test with maybe a VNG to record the eyes, but also we know that it's difficult to know the cervical vestibular reflex pathway, or even if there is no certainly about the nystagmus generated because you press the trigger point on the neck. It's happened so few times. There is something like not for really sure. So maybe we need a objective measurement test for this, but we have not. Or if we think about the posturography, well, that's maybe something, but not really specific to that pathology in consent. So it's difficult, very difficult. So it's an interesting topic we have to talk here, and I'm really pleasant, and I'm very happy for this invitation. So thank you.
Thank you. Thank you, sir. Dr. Ramesh Rohiwal, I think closing comments, you will be the last to go.
At the very outset, thank you to you and Dr. Vishal Pawar for inviting me and participation into this wonderful sort of discussion and webinar. As Dr. Srinivas has correctly quoted and Dr. Diego also has said, we have to keep mind open and we should wait till things are getting evolved. Now we've got to establish criteria of like electrocochleography, even OVM, CVM, like that. Other tests also they will get developed, and we will be having something to support the diagnosis. Bárány Society, of course, they are doing their work, but we should keep our eyes open and we should see the patients and give proper justice by ruling out treatable causes. Those are very important, like undiagnosed BPPV or migraine. A busy practitioner misses taking history in detail of such patients. Thank you very much.
Thank you. Thank you. I think there's a reasonable conclusion that yes, it does, cervical dizziness does exist, but what is when to diagnose, I think remains the biggest question for everybody. Thank you, everyone. Thanks to all the panelists and thanks to the IN team as well. Thanks to Dr. Vishal Pawar for helping put together the panel for today. Most of that was his work. And to all the attendees, if you're not members, I strongly encourage you to become a member of the IA Neuro Otology subsection so that we can keep having these clinical activities going on every month. Thank you. Thank you, everyone. Yes, thank you.
Thank you so much. Thank you. Bye. Thank you.
Thank you.
Thank you. Good night.